Hi everyone, my name is Valentina Zapata and my topic is caterpillar sign infantile hypertrophic pyloric stenosis. First, definition. It's a condition characterized by hypertrophy of the two circular muscle layers of the pylorus, resulting in constriction and obstruction of gastric outlet. It's described by Earsprung in 1888. Infantile hypertrophic pyloric stenosis is a common cause of infantile vomiting. The caterpillar sign is a characteristic finding on a supine radiograph of the abdomen and appears as a single air pocket with peristaltic constructions suggesting.
With hypertrophic pyloric stenosis, hypertrophy refers to an increase in size. Pyloric refers to the pylorus, which is the tissue between the stomach and the duodenum, and stenosis means narrowing. So hypertrophic pyloric stenosis, or HPS, is a congenital condition where a baby's pylorus grows in size such that it narrows the tiny opening between the stomach and the duodenum. The pylorus itself has two parts to it: the pyloric antrum, which connects to the body of the stomach, and the pyloric canal, which connects to the duodenum. At the end of the pyloric canal, you've got the pyloric sphincter, which is a ring of smooth muscle that contracts and acts like a valve, letting food pass down into the duodenum, but not go back up into the stomach. In HPS, babies are born with a normal pylorus, but within a few weeks after birth, the smooth muscle of the pyloric antrum starts to undergo hypertrophy and hyperplasia, meaning an increase in the size of each cell as well as an increase in the overall number of cells, respectively. This causes the pyloric antrum to nearly double in size, and this thick, muscular antrum obstructs the pathway of food, which makes it harder for food to leave the stomach and enter the small intestine. Clinically, the enlarged pylorus can be felt as an olive in the right upper quadrant or epigastric region of the abdomen, which is just above the umbilicus. Also, there's normally contraction and relaxation of the smooth muscle lining the stomach, a process called peristalsis. Obstruction from HPS can cause the stomach's smooth muscle to have to work a lot harder to push food through, and sometimes there can even be a hypertrophy of those muscles as well, which can result in peristalsis that can be felt or seen. If food can't pass through the pylorus, it quickly starts to build up to the point where it has nowhere to go, which can lead to vomiting. This usually happens around 2 to 6 weeks, and can get more intense over time, until it ultimately starts causing projectile vomiting, called that because the vomit literally launches out of the child's mouth. The vomit's also non-bilious, meaning it doesn't contain bile, which makes sense since bile secretion happens after the pyloric sphincter in the duodenum. This vomiting leads to a loss of stomach acid, which leads to dehydration, as well as a loss of hydrochloric acid, which depletes the body's chloride and leads to hypochloremia, low chloride in the blood. Also, due to having a lowered blood volume from dehydration, the kidneys retain salt and excrete potassium, which results in hypokalemia, low potassium in the blood. Hypokalemia results in a movement of potassium ions out of cells and hydrogen ions into cells, as well as secretion of hydrogen ions and reabsorption of bicarbonate ions in the kidneys. These effects all tend to decrease the acidity of the blood, in other words, increase the blood's pH, which results in metabolic alkalosis.
Applications in medicine. Vital signs control, mother's education, laboratory sample collection, and preparing the patient for surgery.
Today we're going to talk about pyloric stenosis. This little baby, how was it, 6 weeks? 5 weeks old, presented here to the emergency department tonight for vomiting, and vomiting right after feeding. But I thought this would be real helpful to actually hear the story firsthand from the baby's mother. The father's not going to be on screen, but he might be able to pipe in here once in a while too. So when did the baby start vomiting?
Started about 3 weeks ago.
3 weeks ago. All right. And tonight we made the diagnosis of pyloric stenosis based on the ultrasound that showed some thickening of that part of the stomach called the pylorus, which is the outlet from the stomach. And so 3 weeks ago this started, and was it every feeding at first?
Yeah.
Every feeding. So when it started, it was like right after every feeding.
I'll say about 20 to 25 minutes after he ate.
Okay. Did he was it a projectile vomiting? A lot of times classically we talk about vomiting that kind of shoots out.
Yes.
All right. So 3 weeks ago, and that means he was about 2 weeks of age.
Mm-hmm.
Okay. Most of the time it's between 3 to 6 weeks of age. It's usually in a male, and it's either 6 to 1 or 4 to 1 as far as male versus female, and a lot of times it's the firstborn son. So he kind of fits in that category. He's a firstborn son, and vomiting, kind of a projectile vomiting, would shoot out about 25, and then he would seem hungry again afterwards, right?
Right.
Just like he was happy still,
Yeah.
but vomit, and then he's hungry,
Yeah.
right? Okay. So how many times a day was he vomiting?
Yeah, I'll say about 3 to 5 times.
Okay, all right. So he may have not. There may be some feedings that he didn't vomit, or
Right.
Few,
right?
But yes.
Okay. Weight loss. Has there been weight loss?
Yes.
Okay. Did he? What was his birth weight?
8'5".
Okay. And then what's his weight now? Rough. You don't know.
I'm not sure.
But you think he's lost weight?
Yeah, he did at his 2-week checkup.
Okay.
With his regular pediatrician.
So was he less than his birth weight?
Yes.
Okay.
He was 7 pounds 2 ounces.
Got it. Okay, perfect. And as I examined him, he seems a little thin, a little emaciated appearing, and I'm wondering.
Issue applied in Ecuador. Diagnosis. Straightforward: when the olive is pulped, the olive is most easily felt immediately after emesis. This can be confirmed by an ultrasound or upper gastrointestinal. Pros and cons. Pros. Treatment is surgical with a pyloriomyopathy, in which the pyloric muscle is divided down to the submucosa. This can be performed both open and laparoscopically. The operation is curative and has very low morbidity. Recurrence is rare and usually due to an incomplete pyloriomyopathy. Cons: edema of the pyloric canal and expanse of the antipyloric muscle, vomiting, and dehydration and metabolic alkalosis.
Is a disorder of young infants in which hypertrophy of the circular layer of the pylorus leads to gastric outlet obstruction and forceful vomiting of non-bilious emesis. Hypertrophic pyloric stenosis occurs in approximately 1 to 4 per 1,000 live births, with a male predominance. Other risk factors include prematurity, maternal smoking during pregnancy, family history, use of macrolide antibiotics such as erythromycin, and firstborn children. Symptoms occur between weeks 2 to 8 of life, with classic presentation of immediate postprandial vomiting, which is non-bilious and forceful. Occasionally on physical exam, a pathognomonic olive-like mass can be palpated in the right upper quadrant. Laboratory evaluation classically shows a hypokalemic, hypochloremic, metabolic alkalosis due to the loss of large amounts of gastric hydrochloric acid and potential hypovolemia. The presence of bilious emesis does not rule out pyloric stenosis. However, it should raise concern for more distal obstructions such as malrotation with or without midgut volvulus. Pyloric stenosis may also be difficult to distinguish from gastroesophageal reflux, in which episodes of emesis are postprandial but not forceful. Ultrasound is the diagnostic tool of choice with sensitivity and specificity above 95%. Hypertrophic pyloric stenosis is characterized by the classic target sign on the transverse view. Criteria for a positive ultrasound include pyloric muscle thickness of 4 or more millimeters and a pyloric channel length of 16 millimeters or greater. Timing of surgery depends upon the clinical status of the infant and should be delayed in the setting of dehydration or electrolyte derangements. Infants presenting with normal electrolyte values and no dehydration should receive maintenance intravenous fluids such as 5% dextrose with 1/2 normal saline and 10 to 20 milliequivalents of potassium chloride per liter. Infants with moderate or severe dehydration require more intensive fluid management with higher rates of administration. If alkalosis is not corrected prior to surgery, it has been associated with an increased risk of postoperative apnea as well as a prolonged intubation. Definitive management is with a Ramstead pyloromyotomy, which can be performed with an open or a laparoscopic approach. The laparoscopic approach is the standard of care with a faster recovery time and return to full feeding, but with a higher incomplete myotomy rate. The pyloromyotomy involves a longitudinal incision of the hypertrophic pylorus, extending from the proximal gastric end of the pyloric channel to the prepyloric vein of Mayo at the duodenal end. This is followed by blunt dissection to the level of the submucosa, allowing for it to bulge, relieving the constriction, and allowing for normal passage of stomach contents into the duodenum. At the completion of the myotomy, each side of the divided muscle is grasped and moved in opposite directions to ensure.
Conclusion. Infantile hypertrophic pyloric stenosis is not a surgery emergency. Infantile hypertrophic pyloric stenosis commonly present at 2 through 8 weeks of age. The infant may be dehydrated and have significant electrolyte disturbance. Diagnosis is based on history and examination and can be confirmed by ultrasound. Thank you.